Interventions for saphenous vein grafts remain a high-risk subset of percutaneous coronary intervention due to the unique pathophysiology of graft degeneration. Unlike native vessel atherosclerosis, SVG plaque is often friable, lacks a fibrous cap, and is prone to distal embolization. The primary risk during SVG PCI is the no reflow or slow flow phenomenon caused by the distal embolization of necrotic core material and fibrin. Historically, SVGs have shown higher rates of major adverse cardiac events and target lesion revascularization compared to native vessels. The risk of intervention increases significantly as the graft ages, particularly beyond the 5 to 8 year mark when degenerative changes become more pronounced. To mitigate risks and improve outcomes, several technical approaches are standard. Embolic protection devices. Distal filters, the most common approach allowing for continued blood flow while capturing debris. Proximal occlusion, used less frequently but effective in specific anatomical subsets where distal filter cannot be landed. Pharmacological adjuncts. Intracoronary vasodilators such as nitroprusside, verapamil or adenosine are often used to treat or prevent the no reflow phenomenon. The role of glycoprotein 2B3A inhibitors is controversial in SVG PCI. While they reduce thrombus burden, they do not necessarily prevent embolization of friable plaque. Stent selection. Drug-eluting stents. Current evidence favors second generation DES over bare metal stents to reduce target vessel failure, though the benefit is less pronounced than in native coronary arteries. Stent sizing. Avoiding aggressive post-dilatation is often preferred to minimize plaque protrusion and embolization. Given the high friability of older grafts, clinicians often weigh SVG PCI against other strategies. Native vessel PCI. If the native circulation is amenable to revascularization, example chronic total occlusion or high-grade stenosis, PCI of the native vessel is often preferred over the SVG due to better long-term patency. Medical management, optimization of intensive statin therapy and antiplatelet regimens. Redo CABG, generally reserved for patients with multiple failing grafts and no viable PCI options, given the significantly higher surgical mortality of secondary procedures. Here is a comparison of outcomes. Plaque type in native vessel PCI, calcific or fibrous. In SVG, it is friable and thrombotic. Embolic risk is low for native vessel PCI while it is high for SVG PCI. No reflow risk is minimal in native vessel PCI but significant in SVG PCI. Long-term patency is high for native vessel PCI, moderate to low for SVG PCI. Foundational trials on embolic protection devices. The use of embolic protection devices is a class 1 recommendation in guidelines based on early randomized evidence showing a significant reduction in peri-procedural major adverse cardiac events. SAFER trial. This landmark study evaluated the guide wire distal occlusion and demonstrated a 42% reduction in 30-day MACE compared to conventional wires, 16.5% versus 9.6% with p-value 0.001. It established that distal embolization is a primary driver of peri-procedural MI in SVGs. FIRE trial. This trial confirmed that distal filter devices, specifically the filter wire X, are non-inferior to distal balloon occlusion guard wire, offering more technical flexibility by maintaining distal perfusion during the procedure. Stent selection, DES versus BMS in SVG. While drug-eluting stents are superior in native vessels, their benefit in SVGs has been more nuanced due to the friable nature of vein graft plaques. The DIVA trial, a multi-center double-blind RCT comparing second-generation DES to BMS in 597 patients. At 1 year, there was no significant difference in the composite of cardiac death, target vessel MI or target lesion revascularization, SRCABG. This trial randomized 610 patients to DES or BMS. Long-term outcomes up to 10 years showed that DES was safe but did not provide a definitive long-term survival benefit or significant reduction in MACE compared to BMS in the SVG setting. Recent evidence has shifted towards refining the lifetime management of patients post-CABG, emphasizing native vessel PCI and optimized medical therapy. TACSI trial evaluated dual antiplatelet therapy versus aspirin alone post-CABG for acute coronary syndrome. It found no ischemic benefit but significantly increased major bleeding with DAPT, leading to recommendations for aspirin monotherapy in stable post-CABG patients. TOP-CABG demonstrated that a time-limited intensification of therapy followed by aspirin alone resulted in non-inferior SVG occlusion rates with significantly lower bleeding risks. Valeti trials. These explored stenting intermediate, that is 30 to 60% SVG lesions with DES versus medical therapy. Valeti 1 showed a decrease in luminal narrowing with DES. Valeti 2 concluded that sealing intermediate non-obstructive SVG lesions with DES was safe but was not associated with a significant reduction of cardiac events at 3-year follow-up. Technical predictors of outcome. A pooled analysis of 3,958 patients from the Harvard Clinical Research Institute EPD data set identified key angiographic predictors of 30-day MACE. SVG degeneration score. It is an ordinal metric of the extent of luminal irregularities and ectasia, more than 20% of the reference normal segment within the SVG, that makes up 25%. SVG degeneration score 0, 26 to 50%, SVG degeneration score 1, 51 to 75%, SVG degeneration score 2, or more than 75%, SVG degeneration score 3, that is of the total length of SVG. Estimated plaque volume. Large plaque burdens remain the strongest predictor of no reflow despite embolic protection.